Hello, my name is Melvi Solbaran, and my current issue in professional nursing is the opioid epidemic. I'm starting with a description of the opioid addiction demographics. Usually they're between the ages of 25 to 55 years old, unemployed, living in poverty, with a family history of substance abuse, a personal history of substance abuse, a history of criminal activity or legal problems, regular contact with high-risk people or high-risk environments, mental disorders, risk-taking or thrill-seeking behavior, and stressful circumstances and prior drug or alcohol rehabilitation. Transition to addiction. A person in the initial stages who uses opioids, they experience the intense feelings of pleasure. The brain's mesolimbic reward system is activated, and the brain's memory that associates these good feelings with the circumstances lead to the craving for drugs when the person re-encounters those persons, places, or things. With time, repeated exposure induces the brain mechanisms of dependence, which leads to the daily drug use to avert the unpleasant symptoms of withdrawal. With further prolonged use, produces long-lasting changes in the brain that underlie the compulsive drug-seeking behavior. This graphic shows what opioids do to your brain. First, it affects the prefrontal cortex and the central reward pathway. So this is a natural link between pleasure and complex thoughts, such as decision making and planning. With long-term opioid abuse, this pathway becomes dysregulated. The amygdala and the midbrain is the part that makes you have the urge to keep using opioids. The midbrain helps steer behavior based on what it has experienced. And this is the area of the brainstem where opioids affect and they can actually suppress breathing and heart rate, and this is what kills people during overdose. I wanted to explain a little of the timeline of the opioid epidemic. The opioid epidemic started in the 1990s, where the pharmaceutical companies started pitching to prescribers and physicians a very low risk of addiction, and they began to promote opioids to treat non-cancer related pain. Around 1999, 86% of patients using opioids were using them for non-cancer pain. Deaths involving opioids began to rise. By 2010, efforts to decrease opioid prescribing began, making it harder to obtain prescription opioids. So people turned to heroin, which is cheap and more available. Deaths due to heroin-related overdose increased by 286% from 2002 to 2013, and approximately 80% of heroin users admitted to start by misusing prescription opioids before turning to heroin. By 2013, there's an increased death related to synthetic opioids like fentanyl. The sharpest rise in drug-related deaths occurred in 2016, with over 20,000 deaths from fentanyl and related drugs. In South Florida, nearly 1,700 people die every year from opioid overdose. Our community is losing its younger generation of people to this epidemic. The families of those addicted many times end up with the burden of raising the children of the addicted and their addicted newborns. The consequences of this epidemic will last for decades and affect the future generations and the prosperity of South Florida. Every day, 130 Americans die from an opioid overdose, and this number is projected to increase in the next decade. In 2017, drug overdoses became the leading cause of death for Americans younger than 50 years old. This is a graphic of the opioid epidemic in the United States. It goes about how 21 to 29% of patients that are prescribed opioids for chronic pain end up misusing them. Between 8 to 12% of those develop an opioid use disorder, and between 4 to 6% who misuse the prescription opioids transition to heroin, and approximately 80% of people who use heroin first misuse prescription opioids to begin with. There is a lack of information about opioid addiction in our community. The more education and knowledge our community gains, the better we can fight this epidemic. According to the National Center on Addiction and Substance Abuse, education and awareness is one way to effectively combat this epidemic. In 2017, the Health and Human Services declared it a public health emergency and announced a 5-point strategy to combat the opioid crisis. Communities all over the United States are losing younger Americans who should be in their most productive years of life to opioid addiction. This graphic shows the timeline when the opiate withdrawal start taking effect, and the symptoms when they peak is at the 72 hours of withdrawal from opioids, and people start getting nausea, vomiting, stomach cramps, diarrhea, goosebumps, depression, and drug cravings. What are the treatments available for opioid abuse? One of them is Narcan or naloxone, which can be injected or inhaled. It treats the opioid overdose and in many cases can reverse the overdose. Methadone relieves withdrawal symptoms and help with detox. It's also used as a long-term maintenance medicine for opioid dependence. After a period of maintenance, the dose can be decreased slowly over a long time. Buprenorphine or Subutex, it treats withdrawal from opioids and it can shorten the length of detox. It's like methadone. Also, it's used for long-term maintenance, like methadone. Clonidine is used to help reduce anxiety, agitation, muscle aches, sweating, runny nose, and cramping. It does not help reduce cravings. Naltrexone can help prevent relapse. It is available in pill or as an injection. It can bring a sudden and very severe withdrawal if taken while opioids are still in the system. The other treatments available are self-help groups, Narcotic Anonymous, Smart Recovery, outpatient counseling, intensive outpatient treatment, and inpatient treatment. What are the benefits of MAT or medication-assisted treatment for recovery? It's proven that MAT helps reduce cravings and withdrawal symptoms. It reduces the drug-related overdose deaths, reduces disease and violent crimes, and improves treatment outcomes. Approaches to stop the opioid epidemic at the Florida state level. Florida, first of all, is not a Medicaid expansion state, and funding for mental health and substance abuse is very limited. Florida has a Medicaid certified match substance abuse program that allows counties to increase local funds for substance abuse treatment for Medicaid recipients. Under this program, enrolled counties contract with providers to offer these services, and then they reimburse the providers directly. Then the county can submit claims to Medicaid for reimbursement of the federally funded portion. There's also software upgrades to the state's prescription drug monitoring program to make it easier to track medication history nationwide. 2-hour continuing education course for doctors to responsibly prescribe opioids. Prescribers are limited to a 3-day prescription, and afterwards extension to a 30-day prescription if warranted and medically necessary. And Florida State joined many other states in suing the pharmaceutical companies. Some of the solutions to the epidemic: some of the states that implemented the proposed solutions, they had overdose deaths drop or level off. A consistent problem that many states face, including Florida, is the lack of federal resources. Addiction treatment remains inaccessible to the bulk of people who need it. Some of the proposed solutions, in my opinion, would be increasing the number of medication-assisted treatments, or MATs, with methadone and buprenorphine, expansion of Medicaid coverage in Florida State, development of non-opioid treatments for chronic and acute pain, prescription drug monitoring programs to track the co-use of benzodiazepines and opioids, and creating provider guidelines, expansion of recovery centers post-overdose, refocusing law enforcement response by stopping the punitive approach towards addicts, develop more programs that train and encourage officers to refer people who use illicit drugs to a case manager for referrals to housing, health, and other programs in lieu of arrest. Some more solutions to the epidemic would be increasing the access to medications like methadone and buprenorphine, limiting excess opioid painkiller prescriptions, needle exchange programs and increased distribution of naloxone, integration of addiction treatment into the rest of healthcare, eliminating prior authorization for naloxone in Medicaid, expanding Medicaid coverage for methadone and naltrexone, and eliminating prior authorization in Medicaid for non-opioid pain relievers, antidepressants, and lidocaine patches. And these are my references, and I hope you enjoyed the presentation. Thank you. Government level, it's the 5-point strategy, which is better addiction prevention, better addiction treatment and recovery services, better data, better pain management, better targeting of overdose reversing drugs, and better research.